can keep your enthusiasm for today, that would be lovely. We should have done that. Me and Katie, of course, taught the same session. This will be our 9th time this week, all right? So if you think you're bored by the end of the day, just imagine where we are, okay? So it's not boring at all. You're going to love it, all right? I'm going to give you those, all right. So we'll do a little bit of general knowledge, A&P, background first. So you've recently had a respiratory day with Andy Parry. If you can remember, in the dim and distant past, it wasn't all that long ago, a couple of weeks maybe, all right? So you would have learnt about the respiratory drive and the respiratory system there, so let's just see how much you can remember, and if you've done your pre-reading, it was all covered, again, in those clinicalskills.net information. Okay, so I thought this was just general knowledge, but apparently it's not. My partner, who's a scientist, couldn't tell me last night what the percentage of oxygen in room air was, and I thought it was just something everybody knew, but apparently not. So, what is the percentage of oxygen in room air?
Isn't it 21?
21. Thank you very much. A very specific number, 21%. Less common knowledge. Does anybody know what the percentage of CO2 in room air is? Can I take any guesses? If you think about CO2 in large, well, in small volumes really, is quite poisonous to humans. What do we think? 0.04%. Okay? So we tolerate a very small amount of CO2. Alright? So, saying that, in normal physiology, okay, so we take oxygen in, yeah, we use it, all our cells, for all our tissues, and to keep all our organs oxygenated.
I'm so sorry, the traffic was terrible.
That's alright, I want you to join a group that's made of 7. Which group was made of 7?
D, wasn't it? It was
D.
the last one.
So can you go upstairs to 4th floor, room 456?
456, thank
Yeah,
you. Beth.
thank you. It's a full house today, I think. Aren't we doing well? Okay, so in normal physiology, when there's no disease state, what is our respiratory drive driven by? Okay, I'm going to give you 2 choices. Is it driven by our desire to get rid of CO2, or is it driven by our desire to take on board oxygen?
Take on board oxygen.
No, get rid of CO2. Yeah. So hypercapnia, okay, is our respiratory drive. So when we feel that our body has got too much carbon dioxide in it, that's when we breathe, because we're trying to replace the carbon dioxide with oxygen. Okay, so in a normal respiratory drive, in normal physiology, we're driven by hypercapnia, okay, so to get rid of the CO2. All right, does anybody know about COPD, what their respiratory drive is? Same 2 choices again.
Take in oxygen.
Take in oxygen, yeah. So they're driven. What's it called when we don't have enough oxygen?
Hypoxia.
Hypoxia. Lovely, thank you. So they're driven by hypoxia. So their low oxygen levels is what drives them to breathe, okay? So you might hear hypoxia and hypoxemia used, yeah, in the same sort of terms. So hypoxia is oxygen in the tissues and hypoxemia is oxygen in the blood. But basically, if you're low on either, you're low on both. So, but you will hear them used together. Okay, target saturations in normal physiology. What are we hoping for from a healthy human being on room air? 96 to 100. Thank you. Okay. How about in COPD? Oh, I believe somebody might have done their pre-reading, because that was one of the things that was in there. Thank you very much. Okay, so you can see that this low target saturation actually is keeping them a little bit hypoxic compared to what we'd normally be, which is keeping them breathing. So what happens if we fix their hypoxia? What's the risk? What are we going to do to somebody who needs to be hypoxic to breathe? what happens if we give them too much oxygen?
They're going to struggle to breathe.
Yeah, they're going to go into respiratory failure, aren't they? Okay, into respiratory distress. So that is why it's really important and why we need to know about these different devices, that we're not creating, well, we're not losing that hypoxic drive in those patients. Hence, we need to know about different types of respiratory failure. Now, there's 2 different types of respiratory failure. Andy would have wanged on about that for about 4 hours at some stage. Does anybody know what the different types of respiratory failure are? No? Okay. So type 1 is when there's a lung or tissue disorder or disease. Okay? So can you think of the sort of thing that might come under that? So pneumonia. Very mild asthma, okay? So it's where the tissues are drowned or where they're inflamed, okay? So the tissue is affected by disease, but what happens is it's affected enough to drive your O2 down, so you're not very effective at taking O2 on board, but actually you only need a little bit of lung function to get rid of CO2, because we've only got a little bit of CO2. So these people generally have low oxygen, but their CO2 remains quite normal, all right? So you will also hear this called hypoxia respiratory failure, okay? So we don't worry about the CO2, they've just got O2 issues. So pneumonia and mild asthmas in this group, okay? How about type 2? So if this is lung and tissue, what else do we need to be working to breathe? Okay, so this is the mechanics of it, the ventilatory system, okay? So this is known as ventilatory or mechanical failure. All right? So, if you think about a car engine, and what we need our pistons to be able to do. Yeah, what do we need to add to our pistons to make them work? To keep them moving? Bit of oil, yeah, to keep that flowing. Okay, so, oh, we've got another person. Yeah, go on, you can come in on this group. We're just getting down in big groups today. So yeah, come in, no, come and sit on. I just haven't got a chair to do something. Oh, she's going to sit down. Okay, so oil pistons, right, okay. What happens when that oil gets old and gloopy and sticky? The pistons start seizing, okay. So, in COPD and in severe asthma, you've got gloop in your lungs. It stops your alveoli from expanding and, yeah, it stops that proper gaseous exchange. So this is where ventilatory and mechanical failure comes in, okay? So this is your COPD and your severe asthma, because here asthma is inflammatory, but with severe asthma it becomes, you know, they're producing, okay? So severe asthma, but also stuff like trauma, all right? So chest injuries, where you can't breathe properly, okay? So again, mechanical trauma, all right? So what type of patients in hospital, who do we cause type 2 respiratory failure in when they come into hospital? They come into hospital with no respiratory issues at all. We operate on a very different part of them, but they end up with type 2 respiratory, or a risk of type 2 respiratory failure. So when we cut somebody's chest open, so heart failure, heart surgery, you see people that aren't able to take in a good deep breath, yeah, because they're so scared of hurting themselves or it might be painful. So those type of people are at risk of type 2 respiratory failure, okay? So trauma there. So in these types of patients, they've lost almost all of their ability there, okay, so because COPD doesn't just affect a little bit of the lung, it affects the whole lung, okay. So these patients have low O2, but they also have high CO2 because they haven't got enough working lung capacity to get rid of that O2, okay? So these patients are at risk of hypercapnia, okay? And we will go on to look at why that is the case. So O2 in expired air, about 4%. So it doesn't sound a lot, but actually if you're not getting rid of it, that can build up pretty quickly. Okay, all right, so there's the science. Make sense? Any questions? No? All right. So yes, it's recapping, but it's recapping on some quite complex stuff, all right? So now what I want you to do is, so this is the A and P, yeah? We're going to go on to the assessment side of things now. So a lot of what we're looking at today throughout every session, this is a spoiler, all right, is about the 2114 exam, okay? So in the 2114 exam, you need to know a little bit about your A and P and your body systems, and then when you assess your patient, how that will affect your assessment and how it will affect your patient. And then we're going to look at treatments, and the review side is looking at whether those treatments are working, all right? So we're admitting a patient, okay, so we're admitting all we know about him. It's Mr. Jones, he's 75 years old and he's short of breath. That's all we know. We don't know anything else about him, all right? So this group here, so we'll use U4 for this group, all right? When you're assessing Mr. Jones, I want you to write down all the things that you need to know about his history, past and present, that might either affect his respiratory system or be affected by his shortness of breath, okay? So what might be causing, or what might the shortness of breath be causing, all right? So I'm going to give you a couple of minutes to do that. You guys, so if you sit on the bed in between these two, one snushing, snushing. Okay, so you're looking at appearance and symptoms. So what might you see when you look at Mr. Jones, and what might you expect symptom-wise, all right, if he's got a respiratory disorder, okay? So I want you to jot down that. And you guys, just the two of you, all right? And you're going to do the same because everybody makes exactly the same. Right? Have I got any asthmatics in the room? Sure. No asthmatics in the room? Okay, good. Right. So, what observations are you going to do on Mr. Jones that might give you a clue as to what is wrong with him? All right. So, is he just short of breath because he's had something else done? You've had
medications that can affect it.
yeah. So think about what you do in relation to that. Alright. So what observations are you going to do on him to try and get a differential diagnosis?
Would it be complex?
So just say like 79 or something like that, and then that's the 100, isn't it? Like, no, I better not. No, I better not. There's more than one. You would go ask him like if you start before his chest. Any trauma related?
How long has the shortness of breath been?
Yeah.
Where did you move it? Which was it?
When I got it small.
Yeah.
So how long has it been carried?
Ages to trust my family.
You're so very quiet. There's 9 of you in this room. Make some noise.
check news on work history,
Oh,
he has worked in
yeah.
places where can affect his
breathing.
Yeah.
For actress,
Yeah.
is it the observations will do or the ones will observe?
No, do and observe. So what are you going to write down on your charts
jokes.
that you've actually
This could be one of
done?
them hobbies.
So if you think, like start thinking about synthesis, if you do A, B, C, D, E, that should help you as well. So look at the airways, what sort of observations do you need to do at the airways? And it's not as simple as, so you need to but what do I want to know about the rasps? It's not just enough to count the rasps, yeah? You want, yeah? What? Yeah, that's it. But like apparently, okay then, let's feed back then and see what we've got. I need my cheat sheet. Okay, so history, guys. What history do you want to know from Mr. Jones when we're so as nurses, right? We're not necessarily diagnosing, but we're looking for differential diagnoses, yeah. So we've got somebody that's short of breath, and we really like to know what's wrong with him. And yes, the doctors are going to decide, but we need to give the doctors all the information that they require, so such as measurements and stuff like that, and history, that will really lead us towards a differential diagnosis. So there might be a couple of things, we say differential, because there are a couple of things that might be wrong with him, but we want to try and, you know, get down to it. Okay, so...
So we'll ask him like, has he had like any past medical histories of asthma or any respiratory illnesses?
Really important.
Yeah.
I'll leave that out.
So like sedentary lifestyles, like is he a smoker, does he drink a lot and stuff like that?
Yeah.
Has he had any past surgeries? Something to do with open chest?
Yeah.
Is he on any like medications that could affect his breathing?
Yeah.
So for example, like opiates and stuff like that.
Definitely. Now, with the past surgery as well, what can possibly be really important? So we said about the chest being open, but what other risk are people at after having recent surgery, no matter where it is on their body?
Sepsis.
Sepsis. What else? Spots in the legs. Thrombosis, yeah, travelling up to the lungs, yeah, it could be causing a shortness of breath as well. Okay, so yeah, definitely.
Yeah. How long has the shortness of breath been? Like how long has it been occurring? His past jobs.
Now, why would jobs be important?
Because like if you look at like for example like a coal miner for example, or like
he's in the right generation of people, isn't he? In the right place. So coal miners. What else? What other? Asbestosis. Yeah. So highest risk of asbestosis. Which employment group? because they all have to take the safety gear into account, don't they?
No.
Teachers, yeah. Who said teachers?
Schools.
Yeah, thank you, teachers. Because they're putting safety pins in walls that are made of asbestos and not realising it, and of course not wearing any safety. So teachers are at really high risk. Yeah. Okay.
Family history. Any past could inherit down from one generation to the other.
Yeah. Definitely. So asthma is quite often
Passed down.
something that's passed down.
And someone said, like, is he like just anxious? That could affect his breathing, you know, like in hospital.
Yeah, so it could be a mental health issue, couldn't it? He could be hyperventilating because he's really anxious about something and has affected his breathing, yeah?
Any other symptoms
Mhm.
that could, like, lead towards?
Yeah, definitely.
What he was doing when it happened.
Yeah.
Oh,
When it
yes.
started.
Right, okay.
What was that?
Yeah. What was he doing when it started,
Ah.
when he started being short of breath? So yeah, absolutely. Think about, so is that your list?
Yeah.
Yeah, okay. So also, 211 full spoiler, think about your ADLs, alright? So activities of daily living. So when you're assessing somebody, how might his shortness of breath be affecting his weight?
He's going to, like, become overweight, innit? Because he can't really move around.
Possibly, or
It could
The
be
other
moving
end?
around.
underweight because a lack of appetite, but it's also what's really difficult to do when you can't catch your breath. Eat, swallow, chew, you know, you don't want to do all those things. So actually, if you work, has anybody worked on a respiratory ward yet? No? If you work on a respiratory ward, you'll find lots of very underweight people because they have to put so much energy into breathing and then can't replace those calories with eating. So we need to be looking at diet and hydration and nutrition as well when we're taking history. How do you eat? How do you manage cooking? All that sort of stuff. You said about mobility might be affected, so we need to be asking about mobility. So when you're looking at differential diagnoses again, somebody that needs heart surgery, so maybe valve replacement, etc., what's the first complaint that they go to the GP with? Not being able to get up a set of stairs without stopping for a breath. So you wouldn't link that directly to you've got a heart issue, but actually that's what they sit in front of the doctor and say, I don't know what's the matter with me, I'm out of breath all the time, I can't even do a set of stairs. And then that's where we start sort of building that from, oh okay, that could be. So linking it to your ADLs, okay, so shortness of breath could potentially impact on every activity of daily living, couldn't it, really? So remember that for 2114. Okay, not bad list, very good list. How about environment? The living environment.
Is he in a warm environment? Is it,
Yeah.
you know, well heated?
Yeah.
Because it might not be sort of heated.
Yeah, absolutely. Homeless. Damp. Living with other smokers. Alright, so second-hand smoke almost as bad as first-hand smoke. Somebody said yesterday, oh, it's alright, I don't smoke, I vape. We don't know what the outcome of vaping is yet, do we? Do you know what I mean? We don't know what the health problems are going to be. We already know that there are definitely some health problems linked to vaping, but we don't know the fuller picture because we haven't had a full generation that has been vaping for a long term. So 10 years down the road, we might be thinking, oh my God, why did anyone ever start vaping? The same as we did with smoking, you know, 20 years ago, thinking, why was that so cool? You know, we didn't know we were killing ourselves then. So, yeah, okay, so really important. Thank you. Good. Right, okay. Appearance and symptoms, what have we got?
Can I do? So we thought that colour would be something to consider,
Absolutely.
whether they were didn't have that flush look.
Yeah, cyanosed, so we're going to use the medical terms today. So bluey. My little boy was diagnosed with asthma because every time he's out of breath or cold, he goes blue around his lips, and that's not normal. So that was how we got our asthma diagnosis. So yeah, so cyanosed, peripheries, etc. Yeah.
Whether he was conscious, we can obviously come so he would have been conscious.
Yeah.
Any we're going off appearance into symptoms, aren't we?
That's
So
all right.
we had for
We'll have
appearance
it,
was colour, and then in symptoms then obviously we had shortness of breath, shallow breathing, so just looking at the chest,
Yeah,
his ability to hold conversation, if he
definitely.
can talk, at the noise of his chest, whether if it was crackling or wheezing or if there was stridor,
Yeah.
if he was in any pain,
Mhm.
his temperature on his extremities, like his hands and feet,
Yeah.
if he was feeling any numbness or pins and needles, any confusion.
Okay, why confusion? What causes confusion?
Hypoxia. Yeah.
And what else? High CO2. So if you think about people in poorly ventilated situations with maybe a broken boiler, does anybody watch Doc Martin? You need to start watching Doc Martin, you know, right? I'm going to start putting it on for you at break
Got
time.
time to watch TV.
Yeah, Jim is studying. Actually, it's a really good studying because differential diagnosis all the way with Doc Martin. He's always thinking about several different things. But they had somebody on there that was slow CO2 poisoning over a long period of time. And what the people in the village noticed was that she was just absolutely barking. And she was beginning to do really odd things and dress in really odd ways and stuff. And it turns out it was CO2, so yeah. What does high oxygen cause? What happens if you have too much oxygen? So if you maybe he's on oxygen, we didn't talk about medications, did we? We need to, yeah. So drugs, yeah, you did do drugs. There you are. So what if they were having too much oxygen? Anybody been to a festival to an oxygen tent or to one of those oxygen clubs?
You get like headed, like almost
Euphoric.
dizzy.
Yeah, you get quite euphoric on high levels of oxygen. So obviously your body sorts that out quite quickly. It doesn't last very long, but yeah, quite a buzz off too high oxygen. So yeah, definitely. What else would high CO2 cause? You said about consciousness levels. What happens when people have too much CO2?
Confusion
And
and
consciousness. Drowsy, sleepy. This is what happens to people, isn't it? They fall asleep and then they die because they couldn't get up to get out of the situation. Okay, yeah.
And the other one was whether they were anxious as well. Because that can implement on
So
the
when you're
people.
looking at somebody, you've listed a whole load of sort of symptoms there, but when you're looking at somebody, what might you actually be... So if I was diagnosing Mr. Jones from the doorway, what might I actually be looking at as far as some of those things go? There were a couple of things.
so you look at the chest.
What does somebody who's in pain look like? They're wincing.
Yeah.
So we want to see facial expressions. Also, when people are breathless, quite often they do a pursed lips or a trout pout. It's not because they're posing for a photo. It's because they're struggling to get the oxygen through. Also, after I've been for my nice long run, how will you find me in the park at the end of my run? Usually lying down. But no, I'm leaning forward and I'm trying to, or equally, I'm opening my chest up and trying to spread my lungs so I can get my most capacity. So it's the appearance of somebody. When you're working in a consultation place, when people walk in through the door, you're already deciding what's wrong with them before they've even sat down and told you what they're there for. You're watching how they walk, how they hold themselves. So that's really important in respiratory disorders. Okay, brilliant. Was there anything else?
No, that was it.
You've missed the biggest one. Symptom. No asthmatics. Anybody know an asthmatic? Anybody own an asthmatic? I own an asthmatic. No? When asthmatics are exerted, what symptom do they have quite often? Cough, really important, alright? So, and this will cross over with your observations, alright? But what is it that I want to know about the cough?
How long has it had it?
How long I've had it?
It's like a dry. Is it
Dry or
Chest.
what's the other? Or productive,
Productive,
yeah. What do I want to know about the product?
Colour.
Colour.
Mm.
Viscosity. Alright? Does it bounce? Yeah, when it hits the floor. Does it slide down? Sorry about that. Yeah, so does it bounce? Does it slide down the side of your cup? What else about sputum? Everybody loves a bit of sputum. Wait till you go on respiratory ward. It's the student's job to cut the sputum in the morning because nobody else wants to do it. So what else?
There's blood in it.
If there's blood in it, what's blood in the sputum called? Heme, obviously.
Yeah.
Everything to do with blood is called heme. Hemoptysis. Okay, hemoptysis is blood in sputum. Okay. What else can sputum?
Smell.
Oh, you can smell it. Oh, yeah. Get very involved with sputum if you really want to. But also frothiness, bubbles. Okay, so that can often tell that there's too much gaseous exchange going on if you have bubbly sputum. So yeah, sputum really, really important. What else about coughs?
Is it persistent?
Is it
Or-
persistent? Yeah. Does it come on exacerbation? Does it come just when you're lying down? What's your position when the cough happens? So a nasal drip can cause a cough when you're lying down because it hits the back of your throat, it irritates your cough reflex and you start coughing. So cough, really important and everything about it. The other thing is the use of accessory muscles when you're breathing, okay? So, yeah, and they quite often have amazing, like long-term respiratory issues, have amazing neck muscles. Because they, you know, fine, that's what you need a respiratory condition. So, if you want those amazing neck muscles, you either need to swim or get a respiratory condition. Yeah, so you'll see, you know, a lot of accessory muscle breathing. Okay, brilliant, thank you very much. Observations, what are we looking at?
We've got follow-ups, the use of your body to breathe, your accessory muscles, if there's any obstructions in the airways, looking at the rests, like how many, the depth, the rhythm.
What else about rasps? Thank you very much, bilateral. If you've only got rasps on one side, what might that suggest? Capsular pneumothorax, yeah, absolutely. Okay.
We've got your peripherals, your temperature, and then if there are any wounds anyway, traumas, surgery, and then if they've got edema.
Okay, yeah, doing really good there. So you're cheating with a full set of obs, right? What does a full set of obs cover?
Your heart rate, your blood pressure, your SATs, rests, temp.
Yeah, lovely, great, thank you very much. Yeah, no, that's really good. That's a really good list. You did really well. Pattern of breathlessness is the other one. Okay, so there's a couple of things that you've missed off there, and I said you would, because everybody does, all right? So, SATs. SATs probe, lovely, on the finger. What affects that reading?
Nail polish.
Nail varnish, yeah.
Temperature.
Yeah.
Temperature, whether I've got good peripheral circulation, yeah. Certain hand creams, all right. What if you chop all my fingers off?
Use the foot.
You can use ear or toes. What if you chop my fingers, my toes and my ears off? You're all imagining me now with no fingers.
I know.
No? No? You don't know? Anyone? Arterial blood gases? Okay. So arterial blood gases will tell you how much O2 you have in your blood. Much more specific, really, because actually this is kind of A star, A plus. I wouldn't expect any of you really to have a great oxygen saturation on normal breathing. I can get my oxygen sats up to 100 if I breathe nice and deeply and really concentrate on it, but normally you wouldn't have an oxygen saturation of 100. So if I'm looking at somebody who's looking a bit peaky and they've just been out of the why would they have an oxygen saturations of 100?
Is your lungs like compensating for the loss when you smoke?
You can actually trick the machine with carbon dioxide molecules, thinking that they're O2. So, I mean, obviously you're not like, it's not cheating a lie detector or anything, is it? But the machine can misread the molecules in your blood as well, okay? So just be aware of that. So blood gases give you a much more thorough reading. And what do also blood gases tell you that oxygen saturations don't? Yeah. What else? Yeah, which is really important in our COPD patients and our hypercapnia, okay? So really important that we use those blood gases, especially when we're looking, and we'll look at the devices and stuff, especially when we're looking at treating these type 2 patients, which will have this CO2 retention issue, all right? So really important for blood gases. And there's one more thing that you've forgotten that's really important in respiratory observation, and everybody's forgotten it this week, even the asthmatics. Take a meter each and a cardboard tube. This is a peak flow reading, okay? So, get on in there. You get to keep the cardboard tube at the end of the day, you lucky cats. I would like some art projects made out of it. And return to snow. We start getting worried. Yes. Yeah. I've diagnosed a few people this week with. Alright, so. Some of you might have children's meters. Who's got a children's meter that only goes up to 500? Me. Yeah, alright. Well, we'll see if you blow that off the Richter scale. You might actually break it. We haven't got any more out. We've had such good turnout this week. I really appreciate that, and it's probably because I've been banging on about it a few months, haven't I? But right, really important. Okay, so peak flow reading measures your total expired volume in one big breath. Alright, so this is really useful and is used in the management of long-term respiratory conditions to see the trajectory of your disease. Alright, so with an asthmatic, when they're first diagnosed, this would be recorded in the doctor's surgery by the practice nurse, alright, and then this would be done every year on an asthmatic review to see how their total expelled air is falling or rising, okay? The other thing that it's really useful for is to see if treatment is working, all right? So if we look at the review side of things, if you've got an asthmatic, you've assessed them, you've diagnosed them with asthma, you've taken your peak flow reading, then you're going to give them a pump, they're going to take the pump, and then they're going to do their peak flow reading afterwards, and you'll be able to see if that medication had any effect and whether it's the right treatment for your patient, okay? We record 3 at each sitting, all right, so they get a good opportunity to be good and bad, but you should also give your patient an opportunity to practice with it, all right? They should be sat up straight or stood, ideally, all right? And it needs to be used properly, because if it's not used properly, it's pointless, right? You're not playing a flute, okay? It can't be done in a ladylike manner, everybody, all right? You have to wrap your gob around it and really get friendly with it, all right? You need to hold your meter level, because if you hold it up like a trumpet, you're blowing against gravity, and if you hold it down, gravity is helping you out too much, all right? So you're meant to have your arrow right at the bottom. Okay, hold it nice and level, and what you want is your total expired air. So a nice deep breath, and then a really good whoo. Okay, so oh, that's better. I need to run. Oh, this one's broken. I'm not like, oh, I'm dead.
So you do it into a machine and it grabs it out. So then when you put your best breathe,
But even
That's
think,
And did you blow it off the container? Did you also blow it out at the end of the weekend? Yeah. Wow. All right. So if you look at the wheelies in front of you, then your height and your age matter. It's all right there. So it does, obviously your respiratory, capacity gets lower as you get older, your ability to fill your lungs get less stretchy. But so it does matter, when you're looking for a baseline, and really important that you have that baseline, alright? So, that's peak flow. Are you all going to spine? You're not. Right, okay. There you are. We do need less people in the third year. You get to keep that as a special gift. Don't say I haven't give you anything. Okay. So, keep mine all day. Alright, so that's a really good way to measure expired volume, alright, so you will see that used. Okay, so now we're going to go on to oxygen devices. Now, have you all used oxygen on your patients? Yes. Have you all looked at the drug chart and seen whether it was prescribed or not?
Sometimes.
Sometimes look at the drug chart, or sometimes it's prescribed?
Sometimes it's prescribed, but sometimes.
Right, okay. It's a drug. It should be prescribed all of the time, alright? You should be, if it's not prescribed and you walk in and your patient is on it, you should be putting it in front of a doctor for them to write it up. It goes on the normal drug chart, alright? Depending on which areas you're in, there might be specific oxygen drug charts if you're on a respiratory ward, okay? But it should absolutely be written up. It's a drug. We shouldn't be administering it without it being written up. And we need to do all the same things that we do with any other drug, okay? So we need to get consent, informed consent. People need to know why they're on it, and it needs to be written up. It needs to be right person, right time, right place, right, all of those things, all right? So really important. There is only one situation where you should be using drug, and you should be using oxygen that isn't written up, all right? And we'll talk about that later. So, several different types of devices for delivering oxygen to people, okay? So I don't expect you to remember it in detail, but if you can remember the general principles, that would be lovely, all right? So we have fixed delivery devices and variable delivery devices, okay? So this is a... No, what is it?
Oh, it's an
This isn't a difficult question. You should all know what one of those is. This is a nasal cannula, and this is a variable delivery device, okay? So you plug it in on the wall, and it's on 1 to 6 litres for a nasal cannula, all right? And this delivers 24 to 44%, okay, of oxygen in room air, just to breathe in room air with it, okay? What will affect how much, apart from the number of litres I got going through it, what will affect how much oxygen your patient is actually going to get out of it? Whether they keep it in properly.
How they breathe, so they're mouth breathers.
If they're a mouth breather, dated a mouth breather once, no good. So, if they're a mouth breather and they've got nasal specs on, waste of time, right? Big nursing no-no, okay? So make sure you look at your patient and how they're breathing before you decide on which device you're using for them, all right? So what else will affect how well nasal cannula are working? So they have to have them on properly, they have to be fitted properly, they have to be breathing through their nose. What other reasons might people not breathe through their nose?
They've got a cold.
They've got a cold, yeah. Waste of time putting nasal specs on somebody who's got a blocked nose, all right? Also, their positioning. So if you're sat up, you take on board more oxygen, so we're looking at you improving your capacity of your lungs. So patients on oxygen should be sat up in bed. If you've got somebody with low sats, sit them up if that's possible, all right? So These devices are used on patients who are sort of post-op, need a little bit of support with their oxygen, are slowly being weaned off oxygen. You will also see them used with long-term home oxygen patients, and we'll talk about what other devices they might be used in conjunction with, but you will see them for people with long-term oxygen. What are the benefits of nasal specs? They can eat properly, yeah. You can talk, you can eat, you can drink without taking your oxygen mask off, so you can carry on to do all those things. So wonderful little things, but they have to be fitted properly. And what are the risks with them? Yeah, so sores here, tops of the ears, and your nasal bit here. Other risk, massive risk with oxygen. Strangulation, yeah. Walking off with them still attached to the wall. Lots of people do that, don't they? Or just, dropping them down their necks and then forgetting they're there. So yeah, there is a risk of strangling. No anyone has been strangled with oxygen. What else is the big risk with oxygen? What is oxygen? It's a gas.
Yes, explosion.
Flammable. Okay, so it's flammable. So they're still doing it out there, and they shouldn't be. So using petroleum jelly underneath the nose and stuff like that, oxygen, petrol. All right. All you need to do is add a little bit of a spark, and you've got kaboom. Okay. So not that long ago, somebody in the hospital died by having a cigarette in a side room by an oxygen vent to the wall.
Did the family try to sue as well?
And they successfully sued, even though he was smoking in a non-smoking area, but they successfully sued. I have, on a night shift on an orthopaedic ward, somebody who was post-op and very confused. She'd been admitted, she'd put all her belongings in the locker, nobody knew that she was a smoker. She woke up in the middle of the night, lit up a cigarette, had an oxygen mask around her neck, and we were sort of sat in the coffee room going, can you smell that? It smells like smoke. Who's smoking? Walked out, and she's just sat there with her oxygen there, just having a nice cigarette. She thought that she was stood at the patio doors, and that the breeze was the breeze through the patio doors. So, quick, turn off the oxygen, take the cigarette off her. So when we're admitting people who are heavy smokers and we're going to be doing some weird stuff to them, take their lighters off them. Tell them that it's for their own safety. They can't smoke while they're on the ward. If they want it back at any time to go down and have a cigarette right outside the main doors, which I love, then they can ask for it back by all means, but in the meantime you'll lock it away in the safe with their belongings. Really good idea, would have stopped that man from killing himself and the trust from being sued. Maybe we should have taken it off him. Okay, so variable delivery device, 24 to 44% on 1 to 6 litres of oxygen. Where should your balls be when you're turning on your oxygen? In the middle of the number, yeah, so cut off through the middle. Brilliant. Okay, this is an MC mask or just a normal oxygen mask. So medium concentration is why they call it an MC mask, okay? So this again is another variable delivery device, better for those mouth breathers, and this is delivering on 6 to 10 litres, 35 to 50% of oxygen, okay? So for people who need a little bit more support or for whom nasal cannulae aren't appropriate for, okay? But this would be hopefully short term. If anybody's on long term oxygen, obviously we can look at putting it through a humidifier because it can be very drying. So you can see there's one set up there with the blue piping. That just bubbles it through a little bit more water, and that's for anybody requiring 35% or more of oxygen.
Do we need to remember these figures for the exam?
No.
Oh,
No, it's fine. It's just for when you're out there, when you're choosing your devices, all right? Okay, most important device that you will see today is one of these. Does anybody know what one of these is? Has anybody seen one of these used?
like a non-rebreathe.
It is a non-rebreathe. What situation would a non-rebreathe be used in? Okay, so critical illness emergency situation. Every patient should have one of these behind their bed, and this is the only, what's this? 2. This is the only device that you should use without a prescription, alright? So if somebody has a cardiac arrest, if somebody collapses, if somebody has sepsis, you're going to be using one of these with 15 litres of oxygen, okay, into a non-rebreathe mask. Every patient should have one of these masks at the top of their bed, and it's the first thing that you access when you go to the drugs trolley, okay? So have a little look around, check what's going on your wards. They should be at the back of the bed so that you can just grab them, plug them in and get them going, alright? Note what time you're putting it on, and write in your notes that you put 15 litres onto a non-rebreathe mask at such and such a time, alright? But don't worry about the prescription, you can get it prescribed afterwards, okay? Only in 10% of COPD patients will this cause a problem. And if you don't get it on there, actually the problems caused by hypoxia are going to be a lot worse than the other issues, alright? So this is delivering up to 80% oxygen, alright? You need to make sure that the reservoir is filled appropriately. If it doesn't fill properly itself, you can touch the... So if everybody grabs, I've put them on your beds there. I nipped yours. Alright, so there's a little valve there and it's one way, alright? So you can touch the valve and it will fill your reservoir up with oxygen when it's plugged in, okay?
Where are you pressing?
The little white bit.
Oh, right, okay.
Yeah? Okay, that'll just let the air into it, alright? So if you put an oxygen mask on somebody like that, a rebreathe on somebody like that and just fitted it, what are you potentially going to do to them? Suffocate them, yeah, because there's nothing to breathe from, okay? So obviously you'll get a little bit of stuff around the outside, which is why it's 80% and not 100%, alright? And they do have to be holes in the mask so that you don't completely suffocate them. But they will breathe directly from this bag, and then when they expel air, it will go out the sides of the mask, alright? So this bag will collapse by 1/3 every time they breathe, and then it will refill itself, okay? So this is the most important bit of life-saving kit that you will come across in a hospital situation, alright, apart from a defibrillator. So 15 litres, non-rebreathe mask, delivering 80%. Don't worry about the
So that's the only one that you would use if there's no prescription, if it's not written out?
Yeah, everything else should be prescribed, alright? Obviously, if you go onto a respiratory ward, talk to them about what they do in emergency situations, if they do anything differently, but I should think that they would be doing exactly the same thing, alright? So those are all variable devices, alright? Variable, 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 because they all deliver variable amounts of oxygen depending on how well they use them. The only fixed device is what we call a venturi, okay? So if you grab your venturis, sorry, I'm speaking all your stuff. Alright, I've got my own stuff, I need to go over here. Right, so this is on a mask, yours is on a, what have I given you all?
24.
What's this though? What's the mask?
Oh, that's for the...
It's for a trachea,
Yeah.
alright? So just because I had trachea masks, they fit onto, alright? But the venturi device isn't this bit, it's this bit, alright? So with thousands of pounds, millions of pounds to some little man who sat in his sheds and worked out the venturi principle, okay? So this is a fixed device, and at the number of litres, so you can see on the side, it'll say 24% at 2 litres on the blue one, alright? So you attach your oxygen to the end, and as the oxygen flows through, it pulls through air into these gaps, alright? So it mixes the oxygen with the air in a very specific amount, alright? So a blue one delivers you 24% of oxygen in room air, okay? So you can see the different devices have got different sized holes in them. This one's 60% at 15 litres per minute on the green one. You can see there's a very little hole in there, okay? So for somebody with COPD, I'm going to start them on the 24% at 2 litres, and I'm half an hour to an hour later, I'm going to do their blood gases, and I'm going to look at whether their CO2 is rising. If their CO2 isn't rising, then I might go up to the 26 or 28% one, all right? And then again, an hour later, I'll do their blood gases, see if their CO2 is rising. And I will keep on titrating up until their CO2 isn't rising, but then I know that's the right Venturi for that patient. So when they go home on oxygen canister with their nasal specs, they're going to have this Venturi valve attached to the canister. Alright, so you don't see it near them, but you see it attached to the canister. So they're getting that very exact fixed percentage of air, okay? Really clever device, really important it's used correctly. When it's prescribed on a chart, if they want it on a Venturi, you'll see V24 2 litres, alright? So it'll be very clearly prescribed on the chart as to how many, what percentage you're looking for. Okay, so if I raise the number of litres that I was putting through this 24, would I get a higher concentration? If I turned it up to 4 litres, would I get a higher concentration?
Say it again. What was the
You
reason?
shouldn't, if it's fixed.
You shouldn't, no, so it's fixed. So all that happens is that I get it through faster. So what situation might a doctor prescribe a V24 at 4 litres instead of the recommended 2? What might the patient be doing that means that they need the oxygen faster?
Asthmatic?
No?
Hyperventilating.
Yeah, RESPs high. So 30, RESPs of 30, then you might see it prescribed on 4 litres, all right? But it's for the doctor to prescribe that. Because if you're breathing faster, you need more air, all right? You're going to run out of air faster. So on 4 litres, you're still getting the 24%, but you can see from the chart there how fast that comes through. So at 24% on 4 litres, you're delivering 104 litres a minute to your patient, all right? So you're not forcing that into them. If they're not using it, it's just going to go out the sides of their mask, isn't it? But it means that it's there available to them, all right? So Venturi, fixed device, very, very clever, very, very important, all right?
At home, would you, because obviously you put that onto the canister, would they use a nasal specular?
Yeah, yeah,
It'd still be okay.
yeah, usually. I mean, you will see COPD patients with masks on at home as well. It's very inconvenient for them, but if they are a mouth breather and they've got COPD, then a mask is going to be... But you might see them switch back and forth between a mask and nasal cannula depending on what they're doing. So they could be so dependent on that little bit of oxygen that they get in that when it's actually time to eat and drink, they'll put on their nasal specs, and then between that they'll stick a mask back on, or when they go to sleep all that at night they'll use a mask. Alright, so you'll see that used in different ways. Okay, so variable, 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 fixed. Alright, just remember that. Go out there and look for those prescriptions, alright, and what patients and how patients are using their oxygen. Remembering that it should be prescribed, etc. Okay, so that's good. Any questions on that bit? Okay. Anyone seen one of these?
Mm-hmm.
Yes? Nebulizer. To deliver, why use a nebulizer over a inhaler?
More effective, isn't it?
Yeah, so what do people with inhalers generally do wrong? Just awful technique, isn't it? You know, some people are really, really bad technique-wise. So if I had an asthmatic come into my clinic and say, my pumps used to control my asthma, they don't seem to do that anymore, I would give them the same drug in a nebulizer, which will turn it into steam and will get it right down deep into their lungs. And if that drug actually works, so I'm going to do a peak flow reading before and after, if that drug actually works, the problem is actually their inhaler technique or the type of inhaler that they're prescribed. So I might look at different inhalers, I wouldn't have to look at different drugs. If I was to give them this and see no improvement, then it's the drug isn't working, the strength of drug isn't working. So it's a little bit more reliable that they're actually getting that medication, all right? It's a very prescribed dose that goes in here, okay? So when you get droplets that stick to the inside of the chamber and stuff like that, don't just leave them there and go, well, that's all finished. Tap your droplets down into the bottom, give it back to the patient for a couple more minutes, okay? Because they need the prescription that's in there. Don't give out nebs at meal times, because inevitably what will happen is they'll go, oh, lovely dinner, I'll leave that by there, I'll just have my dinner, and then afterwards they stick this back on, you come along and go, oh brilliant, your nebs are finished, you take them off, not realising that actually the person next door got more of the drug than they did, because it was being vented towards them. So just being careful that it's being used appropriately, and that patients know how to use it. Compliance improves with knowledge, so if people know why it's important, why they need to be sat up and breathing properly. If you see somebody sat up like this, how much nebulizer are you actually getting, right? So being sat up properly, mask fitted properly. You can see why I'm exhausted by the end of the day. So really important. Okay, well fitted oxygen masks, effective oxygen on eyes, glaucoma. Okay, increased risk of glaucoma. We shouldn't be having oxygen masks that are somewhere like this, alright, that is just pushing oxygen into your eyes, drying your eyes, be really careful of that. And they also aren't meant to be worn as hats, okay, so making sure that if your patient is on oxygen, they're keeping them, because actually, if you've got a patient that's mostly wearing their oxygen mask as a hat, what does that possibly tell you? They don't need their oxygen. So you should be treating people according to their target saturations. So when you see oxygen prescribed on a chart, there should be a target saturation and then an instruction that you can titrate it up or down depending on that target saturation. All right? So if the target saturation is 98% on 2 litres and they're maintaining 98% on 2 litres, you might want to turn that down and see if they can, on air, how they're doing. If not, you pop them back on 2 litres. So target saturation is really, really important, and that's what your oxygen should be based around. Now it's time for a break. I'm going to have a cup of tea. Was that okay? Yes. I know it's a lot of information to take in, but thank you very much. You've got a break now for half an hour, and then you are back. What group are you? B. So the B's are back with ECGs after break in Bay 2.
Thank you.
Cheers, guys. Register on the way in. Stone it, because I told them that if anybody arrived late.